So now we're going to start the second unit, and specifically in this unit, we're going to look at non-musculoskeletal conditions. And we'll be looking at the overall treatment and prevention of these conditions, specifically in the advanced first aid sort of realm. And so we'll be looking at what we can do right away for some of these non-musculoskeletal emergency type situations. So we will begin here with our first lesson on specific conditions. This is a two-part lesson that's going to focus on conditions that really can be managed all-inclusively and don't really fit into some other areas. So we'll be looking at skills in different lessons, but this one we're just going to look at a few conditions. And our first condition we're going to look at now is shock. And so when we talk about shock, shock can be caused by a great number of things, but it is a compensation for low blood pressure. The idea that we are not getting blood flow to our major organs and specifically to the brain. And so our body goes into a protective mechanism where it shunts blood away from the extremities to try to preserve it for those major organs. We're going to increase heart rate and respirations to try to increase oxygen delivery to our major organs. So the signs and symptoms of shock are listed here. And you can see most of these are associated then with this decrease in blood pressure. We see bluish lips or nails as we have less extremity blood flow, similar to capillary refill. We have an increase in thirst associated with the dehydration similarities of low blood pressure. And then a variety of different other collection of signs and symptoms. Our general management of shock is going to be both specific to removing whatever the cause of the initial shock is, and general in the aspect that really all we can do is try to get as much blood flow to the vital organs as possible, and prepare for any potential deterioration with that. So you're first going to start with it is identifying shock, and assessing vital signs is a good way to identify shock with all of these sorts of things associated with the vital signs that we looked at previously. If we do have these abnormal vital signs, we're going to summon EMS for that, control any loss of fluids, and maintain our open airway. Then we're going to place them in a supine position and elevate the legs 6 to 12 inches if there is no spinal injury. And the idea with this is, although there's not great evidence associated with this, if we increase the legs, we potentially have the possibility of directing more blood flow back towards the core and major organs. So we're going to, at that same time, we're going to keep the athlete warm, monitor their vital signs, watch for any vomiting, reassure the athlete, manage any injuries associated with that. But we also need to prepare for the fact that if we do not have the ability to eliminate the cause of shock, eventually this may turn into a cardiac condition as blood pressure goes down to the point where we get cardiac failure, and we would need to provide artificial circulation as much as possible. And obviously with this, we summoned EMS, so we're going to transport them to a medical facility. As I kind of mentioned, there are different types of shock, and with each of these types of shock then, that's where the cause is relatively different. So in hypovolemic shock, we have a total decrease in the amount of fluid below normal levels. So we have either blood loss, dehydration, or vomiting, something that's caused low fluid levels that we call hypovolemia. And so what ends up happening with that is the body has to compensate by moving intracellular and interstitial fluid into the vasculature to maintain normal blood plasma levels. And so because of that, we can get damage to the kidneys and the brain. Signs and symptoms of that are relatively similar to the others: low blood pressure, pale skin, diminished pulse, dizziness and fainting, inadequate capillary refill, nausea, thirst, altered mental status. So obviously very similar to our normal signs and symptoms of shock. Anaphylactic shock now is the reaction to an allergen, right? And so we get a dilation of the local blood vessels and a leakage of plasma associated with histamine release, trying to fight that initial allergen with that. So we can get wheezing, difficulty breathing, respiratory emergencies if the reaction spreads, and we get a histamine reaction in the airways. Hives and local redness is associated with that, as well as possible swelling from that histamine reaction. Really, when we get into this situation, the additional aspect that we get in there is we can administer epinephrine to dilate the airways for a temporary relief. We'll see more of that in future lessons when we talk about more anaphylactic injuries and different causes with that. Similar signs and symptoms: hives, itching, redness of skin, diarrhea or vomiting, difficulty breathing, low blood pressure, fainting, and swelling of lips, face, and neck are all associated with this presence of some sort of allergen. For septic shock now, we have a severe bacterial or fungal infection that occurs and causes then a reaction associated with the bacterial or fungal infection. This leads to that increase in capillary permeability and dilation of the blood vessels. And because of that, then we get a decrease in blood pressure. Signs and symptoms associated with that are red skin, flushed face, neck, hyperventilation, low blood pressure, fever, and confusion. With that, the only way we can really diagnose this is through blood cultures for signs of infection. And then with our treatment, we're going to go with corticosteroids, right, and then treatment of the infection. Neurogenic shock now is from a sudden loss of function in the autonomic nervous system. So in our case, this might be associated now with a spinal cord injury. But you can also get this from fear, horror, or hypothermia, where the central nervous system or autonomic nervous system goes haywire, causing potential shock. Signs and symptoms: hypertension, venous pooling, inadequate cardiac output, bradycardia, nausea, vomiting, cold, clammy skin, and shallow, rapid breathing, all in those same sort of aspects. Cardiogenic shock now is a dysfunction of the heart's ability to pump blood. So whether or not that's from a myocardial infarction, an arrhythmia, some sort of valve dysfunction, all with that, the heart is unable to pump blood, and so therefore that leads to our decrease in blood pressure and then our shock signs and symptoms. We see the same signs and symptoms with that. Jugular vein distension comes into play with that, and with this, because we probably do not have a great ability to affect some of those aspects, but what we do is our CPR sort of aspect. So we need to prepare for CPR transport via EMS with that. Hypoglycemic shock or insulin shock. We'll talk more about diabetes here in a second, but when blood sugar falls below a normal level, we actually get a decrease in this blood flow and changes associated with that. And so we're going to need to treat that with an ingestion of some sort of glucose glucose substance to increase that blood sugar. Psychogenic shock then is just a dilation of blood vessels and a decline of blood pressure due to like fear. This is similar to like fainting type aspect, where we have this temporary lack of blood flow and oxygen to the brain, and we get that fainting, and we just follow our normal management. Hemorrhagic shock then is our last time, is caused by loss of blood and oxygen carrying capacity, and it is actually classified based on the amount of blood that is lost. And so of these, this is the most specific one for us to talk about with our shock, because in this case, right, our cause is to control the bleeding. And we will look at this in the advanced procedures course, where you will learn how to control severe bleeding, because the more the blood loss, obviously the less there is for blood to carry oxygen and therefore lead to multiple organ failure with that. So as promised, next for our specific conditions is diabetes. There are estimated over 29 million individuals in the United States that suffer from diabetes, with over 8 million not aware that they have the condition. It's categorized by type, with type 1 being an autoimmune pathology, where the autoimmune system actually kills the cells that produce insulin, so there's not insulin being produced. And so without that, we have the inability for glucose to be uptake out of the blood into the cells, which leads to chronic high blood glucose measures. Type 2 occurs over time, and it can really occur in any age, associated with obesity and excessive sugar intake, where the insulin is either becomes resistance, or there's insulin resistance that occurs, or the pancreas does not produce enough insulin, leading to chronic hyperglycemia. So the body produces insulin, but either it's ineffective or there's not enough. And then there's gestational diabetes, which can be a temporary insulin resistance associated with pregnancy. It usually occurs around the 24th week of pregnancy with that, and is associated then with an increased risk of developing type 2 diabetes. So the way we diagnose and assess diabetes is through continual blood glucose monitoring associated with that. It's important to measure this on a regular basis. And so there are several different measures associated with blood glucose. Glycosylated hemoglobin, or A1C, that you see the ads for regularly, is designed to average the average blood glucose values over the last 2 to 3 months. And so what it's doing is it's measuring the percentage of hemoglobin coated with sugar. Right? And so the higher that A1C level, the higher the risk of diabetes and complications with that. You also have the fasting plasma glucose. Right? This is associated with a test in the morning before consuming any foods, right? And after about 8 hours or more of fasting, to measure the amount of blood glucose in there. And then there's also a specific test associated with that, where you would do an oral glucose tolerance test, where you'll drink a sugary substance and then they would measure that. And so that's how we can assess your actual and diagnose you with diabetes. But those that have diabetes then have to routinely monitor their blood glucose level, because the reason that diabetes becomes or is included in this area of that is, even though it's a general medical concern, uncontrolled diabetes, right, either resulting in high blood glucose or low blood glucose, can lead to medical emergencies that we would need to deal with. So if there are abnormal values, that means that we're not having good control of our diabetes. And so we need to work with the the personal physician for the athlete and work on different plans and stuff with that. And we'll look at how that can occur here in a second. So when we look at chronic uncontrolled diabetes, right, because diabetes is a failure of insulin, we have chronic high blood glucose levels. And because then the blood glucose or the glucose is in the blood and is not able to be uptook by the cells for energy production, more fatty acids are used. And then during the metabolism of fatty acids, ketones are produced. In these individuals then with uncontrolled diabetes, these ketones can build up, creating what we call a condition called ketoacidosis. And you can see several of these symptoms here, right? And the telltale one being that fruity breath, where you're actually getting glucose into the air exchange with that. That's what causes that fruity breath with this ketone production with that as well. So this can be harmful over a long period of time, but also can become acutely a problem leading to coma or death. You test for ketones relatively simple with a urine analysis that you'll look at in lab. And it's recommended that you check for ketones anytime you have a blood glucose over 240 milligrams. So when we look then at the diabetic conditions as well, like I mentioned, we have high and low blood glucose levels, hypoglycemia and hyperglycemia. Hyperglycemia, right, is that chronic condition associated with uncontrolled diabetes, where we have high blood glucose levels because we do not have enough insulin, or the insulin is not utilized by the body. And so you can see some of the signs and symptoms there associated with changes in thirst and all those. We'll focus right here now on hypoglycemia first. And this is either caused by an excess of insulin, right, or because exercise can actually allow for some increase in transmission and uptake of blood glucose into cells. When we have excessive exercise, we can get a drop in blood glucose levels. When they get below 50 there, we can actually get a situation where there's not enough blood glucose for brain activity. And so if that aspect with those individuals, we would start to then see tremors, lack of coordination, changes in consciousness with that. And so we would have to administer carbohydrates and then check over after about 15 minutes. When we get into then the acute treatment of hypoglycemia, right? Now, if we're in that emergency aspect and we see somebody that's going into possibly that diabetic coma there, look for medical alert tags first and foremost if they're conscious. So that way we can see if this is a possible part of a diabetic situation. You'll see that with that signs and symptoms of hypoglycemia. Remember, general weakness, drowsiness, confusion, dizziness, hunger, headaches, irritability, sweating, all those sorts of aspects there. Then we're going to do our normal aspects in there, maintaining ABCs, our sample history, treat for shock. But because we've got to eliminate the cause, we're going to administer oral glucose. It's recommended that all insulin-dependent athletes carry at least 15 grams of carbohydrates. As you know, this can be glucose tabs. With that, be 3 glucose tabs, half cup of fruit juice, table sugar, you know, a half cup of low-fat milk, and there's all sorts of different aspects when we think of carbohydrate with increasing that. And that should be part of the recommended diabetic emergency action plan for anybody that has a situation where they know they have diabetic people and patients. They should create a diabetic emergency action plan. Also, you can administer glucagon. You don't administer insulin because that is for high blood glucose levels, but glucagon then it can be administered, and you'll look at how to do that in lab, and that actually does the opposite of uh, insulin and increases the blood glucose level. If we have a hyperglycemic case, right, in this case, we have an acute condition, we're going to administer insulin with that. And you can see there are different types of insulin, rapid to long acting with that. And then there are also different medications that you could take orally to try to control the long-term effects then of diabetes and high blood glucose levels. So next, we're going to talk about epilepsy. And epilepsy is just transient but reoccurring disturbances of brain function, right? And it's associated with seizures. So we're going to talk about seizures mainly with that. And epilepsy being one of the causes of seizures. Now, seizures can include loss of consciousness or just an abnormal behavior. And these can occur at any age, and often with epilepsy, these can be controlled by medication. But we can also see seizures associated with severe head trauma. And so we'll talk about all of this at the same time with that. And the only difference being is if we know the individual has a history of epilepsy, then we don't necessarily need to transport or refer them right away if they have a seizure. But if they don't, we are going to transport them right away without knowing that. So a seizure is defined just simply as that sudden electrical discharges of the brain, right? And there are both generalized and partial seizures, where generalized seizures are associated with bilateral electrical discharges from the brain, whereas partial seizures are only going to have those electrical discharges in one specific area of the brain. And you can diagnose these with a variety of diagnostic tests with that. There are also different stages associated, both a beginning, middle, and end as the brain undergoes these electrical discharges and then returns to a normal state over a period of seconds to even hours. So there's these abnormal electrical discharges that affect brain function, and depending on what type of seizure it is, it will manifest slightly different. There's absence seizures, and my grandfather actually had absence seizures with that. There was one time that we were just, he just kind of zoned out. I remember being young and he was driving me somewhere, just zoned out. And we just sat through like 3 red lights because it was about 3 minutes or so with that. But they just zone out with that, and they're not aware that they've even had a seizure. There's atypical absence seizures that last less than 20 seconds in there, right? And these are an abnormal stare. Myoclonic seizures are brief shock-like jerks in a muscle group. Atonic seizures are complete loss of muscle tone. And then the tonic-clonic seizures is what you usually think of with an epileptic seizure, where you get the loss of consciousness, falling, stiffening, and jerking, right? Previously, that was called a grand mal seizure. Now it's called tonic-clonic seizure. Different types of seizures. Look at these definitions just so you know the different types in case you have a patient that has a history of these specific types of seizures. You'll know what those are about. With epilepsy, then, there can be certain triggers that trigger those different seizures, but the actual causes and risk factors associated with epilepsy are very multifactorial and difficult to figure out exactly what is causing the different seizures there. But oftentimes they are associated with some sort of warning signs and symptoms. And in fact, with that, they can actually train some dogs to identify when an individual might have a seizure and help them out with that. We look at management of seizures, which is primarily what we're looking at. First, identify them, and then management. Look for that medical alert identification with that. Because in most of these cases, athletes who suffer from seizures will already have notified you about this, about their conditions and what medications they're taking, as well as their warning signs that are usually associated with that. But there can be instances where the seizures occur as a result of a traumatic brain injury or a severe sports-related injury. So if you have somebody that has a seizure without a history, right, and that's why you're looking for that medical alert bracelet to see if they have a history of that, then it's not as big of a deal. Otherwise, if they do not have a history of seizure, we're going to alert advanced medical care immediately. Other than that, what we're going to do is remove potential dangers surrounding the individual, right? Because some of these are associated with movement. Loose and restrictive clothing that might cause potential airway obstructions or different aspects like that. Record the length of time of the seizure. And the reason for that is usually longer than 5 minutes. Something more might be going wrong. So if you have an individual that even with a history of seizures, the seizure lasts more than 5 minutes, it's recommended that you alert EMS. Similar there, if they have a second seizure or the patient is slow to recover or they have difficulty breathing afterwards, you're also recommended to alert EMS immediately. There are a few things that are from old wives' tale with that as far as trying to restrain the athlete or putting something in the athlete's mouth. The idea here was there's the old saying of you put a spoon in their mouth so they don't swallow their tongue, but they're just more likely to choke on the spoon than with that. After the seizure is over, right, and you don't have the jerking, it may, like it said, may take a while for some of that brain function to reboot with that. Put them in the Haynes position, which is just this position here, sideline on their arm. Allows for good airflow, potential for any vomitus to be dealt with as well. Maintain the airway and administer oxygen if needed, and then treat any injuries associated with that. If the seizure were to occur in water, the patient is pregnant or diabetic with that, then we're obviously going to administer or to alert EMS and transport that athlete there as well. Next condition is stroke. This is third or fourth leading cause of death depending on the year. And strokes are caused by some sort of blood clot that blocks the artery or vessel or anything that really interrupts blood flow with that. So you have blood clots or aneurysms that creates then an ischemic condition, right, which affects the brain function. So we get a situation where we have a decrease in blood flow to the brain, causing brain damage associated with that. And so the extent of the injury then is going to be proportional to the amount and the length of time for the decrease in blood flow. Signs and symptoms of stroke, right? You see some of these different aspects: sudden numbness or weakness in the face, arm, or leg, confusion, trouble speaking. It's all going to really depend now on where the stroke is. And there are, in fact, different types of strokes as well. An ischemic stroke, which is the one where we get a disruption in blood flow as a result of a clot, either embolic or thrombolic, basically whether or not the clot travels to the brain or there's blockage in the brain, right? Causes a decrease in oxygen as we don't have blood flow. So this is similar then to, the typical heart attack where you get a clogged artery, decreasing blood flow to an area of the heart, causing an ischemic condition, which is just a lack of oxygen that leads to cellular death. In this case, it's brain tissue dying because of a decrease in oxygen. But you can also have a hemorrhagic stroke, right? And these are the aneurysms, either subarachnoid or intracerebral, where we get a blood flow problem because of a breakage in the vessel of the brain, which has double problems because the blood is both toxic to the brain, but then you have a decrease in oxygen as well. There are these what sometimes referred to as mini strokes or transient ischemic attacks, or TIAs, associated with this. And this is just a temporary blood flow problem or clot that blocks blood flow to the brain. But this is associated with a high instance of full stroke within 2 days. So it's been estimated that approximately 40% of individuals who suffer from one of these mini strokes will eventually have a full stroke. When we think about management, really, it all comes down to identifying early and then referring them. So the way that you identify this is you're going to just ask the athlete to smile and look for any drooping or other abnormal conditions on one or both sides of the face, right? That's the F of fast, right? You're going to ask the athlete to raise and lower both arms and look for unequal or drifting of one arm downward, which is the A for arms. Ask the athlete to repeat a sentence and look for words that are slurred, and for improper recall of a sentence, which is the S for speech. And then finally, T is for time. If the athlete is experiencing any of these symptoms, refer to a medical facility immediately, because the longer this goes on, the more potential damage is in there. So when we look at stroke management, the only thing we really can do is identify this early, and this FAST acronym can be helpful in that. Next, we're going to look at dizziness, right? And dizziness, I think we're all fairly familiar with. This is simply lightheadedness, feeling faint, or any loss of balance associated with this. There are all sorts of different causes associated with dizziness. And so with this, when we're talking about dizziness and treatment of dizziness, we first need to look for whatever the possible cause is and deal with that over a long period of time. We're going to specifically focus here on acute effects of dizziness, dealing with an acute dizziness episode, not so much then looking at the long-term problems and potential aspects. But if somebody is suffering from dizziness, we need to be looking for those long-term causes. There are different categories associated with this, and you can see them here. Vertigo is this this sense of spinning that's not really occurring, caused by this rapid changes in motion. Disequilibrium is an imbalance without that vertigo. Then we have presyncope, which we've seen before, this lightheadedness or fainting, and we'll also talk about that a little bit more here in a minute. And then psychophysiological, right? This idea of floating that worsens with anxiety, stress, or fatigue with that. There are also some special conditions associated with that. That BPPV, which is this inflammation of the inner ear or other trapped debris within the inner ear canal. Obviously, the inner ear is associated with balance and coordination. And so if we have problems with that, we can get this positional vertigo sensation going on that needs to be treated. And then there are other conditions associated with that, with fluid in the inner ears and different aspects. As far as treatment goes with that, it's really going to be dependent on that cause and symptoms. All we're really going to be doing now is having them sit or lie down until the dizziness passes and refer them if the symptoms persist. So the idea really comes here, right, is dizziness can be something that's just temporary as far as positional, can be associated with a variety of different aspects. If we have somebody that is suffering from dizziness, we have to go looking for that cause. And even for some of these more situational aspects, just as like a pure vertigo, they have vestibular rehabilitation and exercises for postural control that can help deal with the sensation of vertigo with that, along with medications. And so we need to refer our athletes for those additional tests and to find the root cause of their dizziness. So the last conditions we're going to talk about in this first part here is syncope and presyncope, right? And this is either a brief loss of consciousness like fainting, or presyncope that we've seen, this feeling of faint and lightheadedness. It can be caused by a variety of different conditions there with that, but this is more temporary in nature. So this kind of brings us full circle from shock now to the syncope and presyncope, which are either beginning or temporary shock type things. You see the same signs and symptoms associated with that, but with these you're going to see quick recovery, and that's how we know it's different than shock, because of the quick recovery associated with that, as far as somebody passing out or feeling faint with that. The management obviously depends on the severity, the cause, and the symptoms with that, but you're going to treat them basically the same as the dizziness. Sit or lie down until that passes, and then refer if symptoms persist. So that is the last conditions that we're going to talk about here in this first lesson. After that, we will move on to other specific conditions next time.